We also recognize that each individual community has its own unique needs. We want to make sure that we address those unique needs. By the way we care, that's a non-negotiable. We are a caring organization with compassion. The way we educate, we know we have a role in improving the community, and that's going to include education of the community. And the way we innovate. We need to think of new ways to do things in healthcare. When it comes to the community health needs assessment, there are things that Tax Code 501R states that we have to do and state that, and things that we feel we're not best positioned to do in the community, and we need to state that too. So we bucketed it into 3 priority areas. Our priority 1 is where we want to be leaders. We think we have the core competencies and the resources necessary to address these issues head on and lead this change in the community. Next, we know we can't do it all. We need to do partnerships. We need to partner in the community and leverage our relationships across Omaha and the metro area. Those are our priority 2 areas. And in priority 3, there's the ones that we're stating that we are not best positioned to address these. If opportunities arise, we will participate, but as part of Tax Code 501R, we have to state those that we're not going to emphasize. I'm going to go through priorities 1 and 2 in this presentation, talk about a little bit about the need, and then also what we're going to do about that in the community. Number 1, this is ground zero, if you will. This is access to health care. We know there is an issue. The metric that we're really focusing on is emergency room use. It's a very high cost, high resource utilization area, and we know that many of these uses are preventable. You know, we as a metro area at 6.4% really aren't doing that poorly. You know, compared to the U.S. average of 9.3%, we're doing better. Now, we're trended in the wrong direction. Over the last 3 CHNAs, you know, we have regressed a bit here. But the thing we really want to focus on is that red box. 53.7% are truly emergent. That means that almost half of people that visit emergency rooms are non-emergent. They're there for reasons because they can't find access or can't gain access in other settings. It's weekends, it's after hours, they can't afford it. They have to go to the emergency room because they have no better options. That's what we as providers of healthcare in the community need to address. Methodist Health System is a regional provider of healthcare. I've illustrated in this map all of our primary care settings. Everywhere you see a Heart and Dove, we have a primary care office. That's family medicine, that's internal medicine, that's pediatrics. In addition to that, where we're going to focus our strategic changes is going to be in the areas of providing additional access, and I'll say where our consumer wants it, when they want it, and how they want it. Through ways of urgent care, immediate care, and e-visits, we shouldn't have to make them schedule an appointment. We shouldn't have to have them face the challenges of getting to our clinics. We shouldn't have them taking time off of work. We need to be available for our consumers, for our patients, for our families when they need it. The other thing is we can't have burdens due to cost. Financial assistance policies across our health system, along with all the other health systems, are really going to aid in that and have been. The other thing is we're focusing on transportation strategies to allow patients to find us and get to us more easily with us providing transportation solutions. The other thing we're looking at from an access perspective is taking care to the community. We're putting locations in areas of need. Our Methodist Community Health Clinic located at the Kuntz Memorial Church is something we're very happy about. We've been asked to partner in that location. We have great growth. We're seeing people using this site. I was asked last time I presented for stats, so I brought it to you this time. In 2018, we had 2,640 patients, and in 2019, we're on track to see 2,800. So we're seeing good growth there. People are using it. The community's embracing that location. Another thing is that's truly a place for partnership. We look at that as a hub for community relations. It's right next to the Kuntz Commons. It's a food pantry that welcomes people from the community in. We use that as a great opportunity to engage the community. They're there for the food pantry. We're going to use that and leverage it and offer types of screenings and educational events inside the Kuntz Commons with our partnership with the church. The other thing is we decided to put care on wheels. I think this is a very innovative way of not making people find us, we're going to find them. From an education and prevention perspective, when it comes to diabetes, one of those areas of need on the Community Health Needs Assessment, we've created a coach. It's the Methodist Mobile Diabetes Center, and we take that and we take it into the community to offer those education and prevention services. We're at 1,400 individuals screened in the last year. We're really happy with that and us taking that innovative approach to prevention and education. That was so successful, we created the Methodist Mobile Mammography Unit. And this is an actual 3D mammography digital mammography inside of a coach that we can take to community locations. We've been at the federally qualified health centers. We've been at large employers. We're out there saying we need to get more early identification of breast cancer. Through our mobile mammography unit, we've seen 1,600 people in the first year of operations. We all know that social determinants of health are challenging. We've been working to incorporate into our electronic health record so that every patient is screened for social determinants of health. Is it a transportation issue? Is it a fiscal issue? Behavioral health, food inequity, whatever it is, we can screen for it, but the real question is, okay, what if they say yes? What if our patients answer, yes, I do have a problem with that? Well, we have a duty, we have a responsibility to then do something about it. We've acquired through our Nebraska Health Network, that's a partnership between us and Nebraska Medicine, Bertha. It's a software and service that gathers information about community resources that are available to help people with these social determinants of health. So we have at the fingertips now of our providers in the exam room the ability to look up those community resources, refer those patients to it, and then document it in the electronic medical record so that we can follow up to ensure that they close the loop and actually do access those resources. We're just in the initial stages of that, but we're very excited to see where this is going to go with our partnership. When it comes to cancer, we know that we have a prevalence of cancer, and we're not really, as a community, higher than any other community when we look at the peer groups in the Community Health Needs Assessment. The challenge is our mortality or our survivability. That's the challenge. We have more people dying from cancer than other communities. And we have that as a real challenge to us. We know that that's early identification, that's behavioral modification. So what we as a health system are doing is, one, trying to identify cancer earlier. Through our cancer screening programs at our Methodist Esbrook Cancer Center, we know that we need to look at lung, head and neck, colorectal, skin, and breast. We're doing that. But we're also taking those screenings out into the community, not expecting people to schedule their own appointments to come in and get screened. Let's do community events, and let's go out at the National Health Week, Black Family Health and Wellness Association, doing those screenings in the Kuntz Pantry to make sure that we identify cancers early so that we can improve survivability. We donated land to Hope Lodge. We know that cancer treatment is not a one-day thing. It's a long process. And we have people coming in from a region that need housing. They need a place to stay while their loved ones are getting cared for. The patients themselves are getting cared for. And hotels are expensive. So Hope Lodge with the American Cancer Association is a great solution to provide those housing alternatives for patients receiving treatment. We also know behaviors cause a lot of cancer. And smoking's number one on the list. So we're really focused on smoking cessation. We sponsor and co-partner with the No Tobacco Challenge to make sure we can get people either not start smoking or to be able to quit. We also provide genetic counseling across the community to other hospitals. When it comes to heart disease and stroke, that mortality or survivability is isolated. We have a disparity here. If we look at races, we know that we have a bigger population, the metro area black population, than we do others. Well, what are we going to do about that? How can we improve that so that we don't have that disparity or inequity? Well, we participate with the Mission Lifeline. We work with the EMTs to make sure that when heart attacks occur, we streamline, we standardize the care that people receive. We want to make sure that those outcomes are the best that they can be because they go through a process that's streamlined, it's quick, it's efficient, everyone knows what they're doing, and it's standardized so they do it the same way every time. Specifically, we're working with the Black Family Health and Wellness Association, the North Omaha Community Care Council, to do those types of screenings. Again, let's identify high blood pressure or hypertension. Let's get out there and do prevention education, counseling, and then plug them into the care that they need to receive. We're doing a number of monthly screenings just like those, the blood pressures at the Kuntz Food Pantry. Mental health and substance abuse, we know this is a huge problem in our community. Here we see a disproportionate share of prevalence of chronic depression in a geographic area, Northeast Omaha and Southeast Omaha. We know where the problems are. What are we going to do to fix it? Number one, we're going upstream. We're trying to get in front of these behavioral health issues by getting in the schools. Our Methodist Community Counseling Program is in now all of the OPS high schools, all of the OPS middle schools, and since the last time I presented to you, we're now in all the alternative programs. So we are now in every one of those areas, and we're seeing 8,300 kids a year. We are billing Medicaid now for those services. That's new since the last time I presented to you. When we look at our primary care offices, we know that we need to be able to provide resources for behavioral health. We're partnering with Lutheran Family Services to do that. When a behavioral health issue is identified in the primary care office, the primary care physician is not often equipped to address those issues. Where a professional licensed behavioral health specialist is, we've put them inside the clinic at our Methodist Community Health Clinic and have a warm handoff so that the primary care provider identifies the need and can then do a warm handoff to a specialist that's trained to address those issues. Something in our community that we know is an issue, it's opioids. This is something as a nation that we need to focus on. Methodist Health System has a reduction effort. We've reduced 740,000 prescriptions for opioids. We couldn't do that alone. We're definitely partnering. You can see the long list of folks that are involved in the efforts to reduce those opioids. When it comes to nutrition, physical activity, and weight status, there's a direct correlation between obesity and chronic health issues. And the thought is if we can prevent obesity, we can reduce the prevalence of chronic pain, activity limitations, poor physical health, diabetes, asthma. You go down all those chronic conditions. If we can reduce the amount of obesity, we can reduce the overall burden of those chronic conditions. Now, this was one, the last presentation I made to the board, this list was pretty small, and I committed to you that we were going to make this list bigger of what Methodist was doing in this space. We have partnered with the Food Bank of the Heartland. We asked them what they need, didn't know what we were going to get as an answer. They said, we need people, we need volunteers. So we've provided people and we've provided volunteers to help the food bank do work that they do to help food access in the community. Our chefs from our kitchens, we have trained chefs in all of our kitchens. They're going out and doing nutrition and cooking demonstrations into the community. We're really focused on this next one, which is food waste reduction. We have, I think, 7 kitchens across our health system, and the amount of waste, particularly perishable food waste that occurs in each of those kitchens, is an issue. We want to see that find its way to the pantries, to the kitchens across the community of those people that need help with that food. So we're working with other organizations to make sure that pipeline occurs. We're partnering with the YMCAs for physical activity. We're swimming way upstream on this one. There's research that proves that if breastfeeding is done right, that baby has a much better likelihood of not being obese. We're providing lactation services for moms and their babies at our Methodist Women's Hospital, as well as Methodist Jenny Edmondson Hospital and Methodist Fremont Hospital. Partnering with Hy-Vee, when we have patients with known food inadequacies, we're providing food for them through the gift card program. Injury and violence, we found a very niche. We had to figure out where we were going to be in this space. We selected sexual assault. We want to assist the survivors. We obviously developed some best practices in how to assist survivors of sexual assault, mostly through our emergency rooms, but now we're taking those best practices and coaching and teaching other hospitals around the community. We are also working at the state level for advocacy to increase the amount of convictions that we see for offenders. Car seat education and shaken baby syndrome are also areas at the Methodist Women's Hospital that we're focusing on violence. Last one is sexually transmitted diseases. I know Douglas County has been focused on this for quite some time. We're now partnering with the Nebraska AIDS Project. We offer a free clinic, and we also offer rapid testing in our hospitals for sexually transmitted diseases. I want to shift gears, just highlight one thing that we found, and maybe if this, as other hospitals pay attention to these types of initiatives, that we can all get into this. We found a group of passionate people, and we have 8,500 employees. Within those 8,500, there's a group that are truly passionate about community work. They are our Methodist emerging professionals. It's a bunch of early careerists that want to figure out where they fit and how they can maximize their career. They are passionate about developing. They're passionate about becoming future leaders, but they're also passionate about making an impact. We sponsored that group. We created it a year ago. We said, you know what, if you're looking for development, you're looking for leadership opportunities, why don't we hand over a number of community-based projects, programs, let you develop them, let you organize them, and let you run them, and then you participate in them. We allowed them to do that. Just in 2019, they had over 100 hours of community service that they organized, that they identified, and that they did at organizations like the Food Bank, the Women's Center for Advancement, Phoenix Academy Together Inc., and Stuff the Pantry. Really excited to see where this one goes. It's a passionate group, and I'm really supporting them in their efforts. Okay, specific question was made to us to prepare information about Medicaid expansion. It's a difficult concept. It's not easy, and it's not something that we have even done yet. You know, we're still modeling. I tried to put this in the best terms that I can. I'm going to start on the left-hand side. Our total commitment to the community, which we've been tracking for quite some time, is $77.4 million. we always gauge that, or we normalize it as a percentage of our total budget. So that is 7.98% of our total spend. We have a strategic target that number should always be above 7%. And it always has since I've been presenting to you. So we're in the green there. We stratify it. We put it into 3 different buckets. The biggest bucket is our community health improvement. That's essentially what we invest back into the community. So of the 77.4, 53.4% goes directly back into the community in terms of time, effort, dedication to the community. The other 2 buckets are, 1, subsidized care, traditionally known as charity care or financial assistance. Okay, that's essentially the patients cannot afford it, whether their out-of-pocket expenses are too great or they simply don't have insurance. That's that bucket at $7.1 million. Then there's $16.9 million, and that is essentially the loss, or that's the amount that Medicare, Medicaid does not cover our costs. We can count that as a community benefit. So as Medicaid expands, number one, I want to point out, and we've done the analysis, that our contracts with Medicaid essentially cover about 80 to 85% of our costs. So there's not a profit there, but there is more money in it essentially than there would be for an uninsured patient where you get no reimbursement. That's the whole point of access, and that's the whole point of expanding Medicaid, is to provide additional reimbursement so that those patients aren't limited in terms of their access. So 2 things are going to happen with this, what we'll call new money. Number 1, the 20 to 15% is still going to be a loss, and that goes into the unpaid costs of public programs. That number will go up as the subsidized care will go down because people have new insurance. The rest of it, that 80 cents on the dollar to 85 cents on the dollar, gets reinvested in the yellow arrow back into the community. We see that as being able to take that, we'll call it new money, reinvest it in our medical homes for prevention, education, wellness, chronic disease management, into the coordination of care. These populations need a great deal of coordination of care. Make sure they get to the appointments, make sure that they get the care that they receive, and then also focusing on social determinants of health. Now, what I'll tell you in this next quote, access is key for residents of Douglas County. We have experience with this. We have a hospital in Council Bluffs. Iowa is a state that already expanded. Iowa has had this happen to them, and we've experienced exactly this in Council Bluffs. There's programs like Connections that came from this. It's a community partnership that does the behavioral health, that does the area of aging, that does all the needs that the community that they demand. That's where the funding for that comes from. So we have this experience in Council Bluffs, and we expect the same thing to happen here. The challenge is we don't necessarily know what the scale of that will be. You know, we as healthcare providers in the community are all going to be committed to providing that additional access. Go ahead. Essentially, we'll say a patient that comes in covered by Medicaid, the cost that it takes to care for those patients are not covered. 80% of them are, 85% based off the reimbursement that we get from Medicaid.
And subsidized, somebody comes in, nothing at all.
Then you get nothing. That's right. Okay? Can I move on? Yeah. Okay, thank you. Okay, I want to take this opportunity to introduce Mike Kraus. He's our commitment to community coordinator. I told Mike, all I want is partnerships. I want you out in the community making partnerships. We can't do this alone. We need to get out there and we need to leverage the relationships that we build. Last time I presented this list to you, we were at 201. That was now grown to over 260. So we're continuing to make friends in the community, if you will. We're continuing to work together as a community. I would be happy to answer any other questions you might have.